Hi, everyone. Welcome to Beyond the Script. I'm Ivy Catherine, and today we have Dr. Zainab Abdurrahman. She is the president of the Ontario Medical Association and a practicing allergist and a clinical immunologist in the Greater Toronto Area. She is an assistant clinical professor at the Toronto Metropolitan University School of Medicine and an adjunct assistant clinical professor in pediatrics at McMaster University. She earned her MD from the University of Toronto, completed her pediatrics residency and subspecialty training at McMaster University, and holds a master's degree in statistics with a specialization in biostatistics. A strong advocate for health equity, medical innovation, and inclusion leadership, Dr. Abdurrahman has contributed to initiatives such as the Black Scientist Task Force on COVID-19 vaccination equity and the Black Health and Vaccine Initiative alongside the Black Physicians Association of Ontario. She is deeply committed to systemic change and to advancing patient care through the thoughtful integration of technology and medicine. And she's here with us today. Thank you for being here.
Thanks for having me.
I'd love to just start out by asking, how and when did you know that you first wanted to get into medicine?
Wow. I definitely know it was early in my childhood.
Really?
I was lucky. My dad is a pediatrician, now retired pediatrician. So I had some insights into what he did, and I liked the thought of him going to the office and seeing kids and talking to kids all day. And I had a cousin who was in vet school as well. So I had some experience and hearing about being in medicine or, in healthcare. So I really wanted to I wanted to be in medicine, but specifically I really wanted to see children. But I think as a child, it was very appealing to go to work and see kids all day.
Right.
But I actually did keep up with that interest as well. Yeah.
Wow, that's really cool. So it kind of runs in the family a little bit.
A little bit, yeah.
Yeah, nice. So what drew you to allergy specifically?
Yeah, it was one of the specialties that has a lot of very common things, but also very uncommon things. So you have your common, regular, environmental allergies, food allergies. Those parts are very common, very much seen across. But then also you have the mystery part of it, which is when you're trying to figure out an immunodeficiency and you're getting to some of the rare diseases. So it was a nice balance. And it's one of the few subspecialties where it's combined still. So we're able to see adults and children. So even though I'm from pediatrics, I can see adults and children in my practice of my subspecialty. So that's also nice. Kind of opened it up a little bit too. Mm-hmm.
Is there a difference that you see between adult patients and child patients in terms of allergy?
We see the predominance of food allergy presenting in childhood. There are some that do present in adulthood, but a majority of food allergy does present in childhood. So we see a little bit more of that. We see a lot more of what we would call some of the primary immunodeficiencies also in childhood.
Okay.
And I think it's just different too. I think in childhood too, there's a lot more factors. It's not this one little person making all the decisions. They're obviously in a family unit. There's a lot of other people, so it's also different.
Yeah.
And then there's a certain amount of time you have to be around to develop environmental allergies too.
Okay.
Because you have to see them over and over. So some of the seasonal ones don't happen until you're a little bit older.
So is that what you see more with adults then?
You'll see it, or just older children.
Okay.
Yeah. So, if, for example, you might see pet allergies in a very young, even in a little baby, you can see that because if they're exposed to them all the time.
Yeah.
But something like seasonal, you have to be around for a few seasons. So you don't typically see it till you're 2 or 3 or older.
Okay.
So we typically see that more in the school-age children.
Okay.
Versus the very young children who we might see more for food allergies.
Right. Okay.
So, yeah.
Wow. So would you see, would an adult come in and say, I never was allergic to this, but now all of a sudden I'm having this flare-up? Is that common, or is that more of a misconception?
No. So we'll see kind of both. So we'll have people who have never had any environmental allergies, let's say, and then they're 30 or 40 and then start to develop it. So you can develop allergies later. Or we'll see adults developing new food allergies. For example, shellfish is something that we see more in adults. Or some of the fresh fruit ones, which is often you've had allergies to some of the environmental allergens, and then you get this oral allergy syndrome where you start to have issues with some of the raw fruits.
Oh, okay.
Because your body thinks you're eating pollen when you're eating the raw fruits because there's some cross-reactive proteins.
Oh, wow.
But yeah, so like common would be apple. So people have raw apple issues, but then they'll get like itchy mouth, sometimes swelling in their mouth, but they can eat an apple pie. So it's a bit confusing.
Oh, that's interesting.
Yeah, and that's just because the cross-reactive proteins are not heat stable. So once you cook them, it's fine.
Oh.
So
yeah,
you see kind of just different things.
Yeah.
And I think what's harder for adults when they get a food allergy is like you've been eating this for so many years. You know, most children may not remember having something. It's actually sometimes harder to get it back into their system when they can eat it.
Okay.
Versus for the adult, for example, with shellfish, they might have loved this for 30 years and now they had a reaction. And, you know, it's hard. I think mentally it's hard. It's something that you enjoyed.
Right. Fair enough.
So,
yeah. Okay. So, of course, allergies are incredibly common, but they're also pretty misunderstood, it seems. So is there a certain myth or something that you would like to clear up?
Oh, wow, there's so many.
I'm sure you can think of many. You can list a few if you want.
I think the biggest thing I would say that I want to clear up is that we should use the right words. People often just say, I have an allergy to something if they don't tolerate it or if they don't like it. But, you know, we do have to be careful with the words we use. Yeah. So, you know, someone might say, I want to see an allergist. I've been having lots of stomach aches and I can't figure it out. And, you know, we often say, we're actually not the best people for that because we see what we call as kind of classic food allergy, which means that it triggers a very fast responding part of your body. It triggers your immune system that has a very quick response, this part of your immune system anyway. And so then it can have like breathing problems, swelling, dropping blood pressure. Your reaction typically starts within, 30 minutes of eating that food, 30 to 60 minutes, and really can go quite quickly into a severe reaction. So I often tell people, when people see me, it's often not the mystery of what the food is. Yeah. Do you know what I mean? They're often like, I ate this meal and this happened and it's one of these 3 or 4 things. Yeah. And it's more of sometimes of that when you've eaten a combination. Okay. Rather than I've had chronic symptoms for a long time. Okay. Is there an allergy causing it? That's not an allergy per se, but there's a lot of intolerances. Okay. Yeah. Which are different. And so I think that would be probably the biggest myth is that people think that intolerances are food allergies. Yeah. And that we can test for them, but we can't. Wow. We're really testing for a fast-acting antibody, which is IgE, and that mediates food allergy. So, you could be tested and you'll be negative, but it doesn't change the way that you're still not feeling great with this food. Yeah. So I often tell people, I'm like, I only test for like a very limited range of responses. Yeah. And so I think that'd be important. The other thing is we can't predict. People often want to come in and get tested ahead of time. Okay. I want to know what my child will be allergic to. Do this testing for the foods. And unfortunately, that's not the way it works. Your body has to be exposed. It's like even developing the environmental allergies. You have to be around for enough to develop it. And so your body needs to be exposed to these foods, and then it makes a decision. Okay. And sometimes it makes the decision quickly, early childhood, first few feeds, or it could be 30 years later with your shellfish. But once it makes that decision where you have a reaction, you started producing IgE to that food. Okay. And then I can test for it. Oh, okay. So I'm not really able to help predict ahead. Yeah. And this test is really based on us having this kind of predictive probability, which means that, we have this reaction, so then you know how to understand the test. Mm-hmm. A test by itself really doesn't do much. Right. And I think people think of me as a testologist, and I would say, actually, I'm more of a history person. Yeah. And so when you see me, I ask you a lot of questions about the incident, what you were doing, what you had earlier. Did you have medication? Where were you? Were you out of your regular habitat? Could you have been stung? Like, I'm looking at all the possibilities. And that part, the history, is actually often what tells me the most, more so. And then the tests can help confirm or maybe rule out because I've kind of dwindled down to a few, and then it kind of helps with that. Yeah. But I tell everyone the best test I have is the history. Yeah. I mean, that makes a lot of sense.
So the language you said is a big part of
Yes.
it. I feel like I've heard people say like, oh, whenever I eat like scrambled eggs, I get a stomach ache after something, and they assume that's an allergy. But maybe a stomach ache is not actually a symptom of an allergy. It's more of just maybe an intolerance, like you're saying.
Yeah, especially when it's like just kind of like a bit of like discomfort. It can happen hours later.
Yeah.
The GI, you can get GI symptoms with a food allergy. It
Okay.
tends to be pretty fast in onset, where you're having like either rapid vomiting happening within like 30, 60 minutes, or having diarrhea right away.
Yeah.
And you'll see it consistently. So I often tell people, there's some people who, for some reason, you're right, they don't tolerate food in a certain way.
Yeah.
So like they'll tell me, I don't get it. Scrambled eggs do bother me,
Yeah.
but I can eat sunny side up eggs, no problem.
Yeah.
I'll say, if you're allergic to eggs, you can't have them in any of those
Yes.
kind of forms, whether it's scrambled or boiled, people are still having reactions.
Yeah.
So it's a little different.
Yeah.
And intolerances as well, people will say, well, I can eat so much, and then, then I'm going to start to feel a little bit yucky. And it's often hours later, because it's got to get to your digestive system. That takes a little while before then it kind of irritates there.
Yes.
So it's a little different.
Okay.
So, and that's why it's all about that history and really clarifying. And so sometimes we kind of go through and say, oh, you know what, this is very clear based on the history. This isn't in keeping.
Yeah.
But you might have an intolerance. The harder part, though, with intolerance, which is why I understand why people want to see someone, is that it's not always easy to figure out what you're intolerant to. We eat multiple foods at the same time, often in combination together a lot.
Yeah.
And so it's not something I'll be able to differentiate for you. I often tell people you have to really do the food diary and start looking and then trying to separate out things and trying to identify it. There's no quick way, unfortunately.
It's quite a process, it sounds like.
It's a process.
Yeah.
And you have to really listen to yourself. And the thing about intolerances is if your body's otherwise okay, you might be better at times. But if you're already having stomach aches or you're a little bit off, you just had like a stomach bug, you might have worsened symptoms quicker just because your GI system's off.
Right. Yeah.
So I get it. It's very frustrating.
Yeah, absolutely.
It's just unfortunately not something that can help, like skin testing would help you with.
Right. Is there a way that you kind of have learned to comfort patients when they get frustrated about maybe not getting a diagnosis or not getting the test that they're expecting to?
Yeah, I think I'm just very open about it, and I'm very clear that, you've explained that you're worried about these foods. This is not the mechanism for which it's using, this kind of fast pathway. And I said, even if we did the tests, they would be negative, but I don't want you to take that to mean that that you're not experiencing this. I believe you, and I'm just telling you these tests are not going to help because they'll be negative, but these foods will still affect you.
Okay.
So, don't do a test that's going to make you potentially even just think, why isn't this working? Why doesn't it make sense? But it's the wrong test.
Yeah.
So don't put a lot on this test that's actually not going to help you. Let's talk about what we can do to help you.
Yeah.
And unfortunately, I do say to them, you're going to find out that I'm going to put a lot of onus on you, unfortunately, because I need you to sort it out. And it's a bit of a mystery where you have to figure it out and really do that food diary and pay attention to yourself and see, And there's some people who have certain foods that really bother them. Some people, but you really got to listen to yourself and figure it out.
Yeah.
Unfortunately, medicine doesn't tell us everything.
Yeah.
We don't have tests for everything. And sometimes we just need to be a little bit introspective and say, okay, I notice when I'm, 'cause sometimes it's a combination. Like when I'm very stressed out and I have more milk or whatever, it does bother me more.
Yeah.
But actually I can have a cup of milk, or half a cup on a day-to-day if I'm okay, because, intolerances can respond when you're also very stressed. So I think that you have to also be aware of that.
Right. And I'm sure it's probably kind of a slippery slope with, like you said, saying to the patient, I believe you. I believe you're having these symptoms. I'm not trying to say that. I'm just trying to say that I can't actually do what you want me to do right here. Like,
this test won't help you get any further.
Yeah.
And sometimes I've like some people who've had they come to me and they said, I had all these tests and they were all negative, and and I'm asking because they might come to you for a second opinion.
Yeah.
And they say, I had all the food tests, they were all negative, but I'm having all these problems with foods. And I said, yes, this is not the test that you needed.
Yeah.
And that's the thing. I said, don't think just because, the test was negative, but that wasn't the right test.
Yes.
And I just don't want people to think that this negates what they're experiencing.
Right.
And so I don't want people to feel frustrated from that because they're just like, if you just give me the test, I know it would tell me so much. But unfortunately, I think it just ends up with more confusion.
Yeah.
But it just is not the right test.
It's not how it works, yeah. Mm-hmm. I'm curious to know if there are any allergy trends that you've seen, or I guess misinformation about allergy that you've seen on social media that concern you.
There's many.
Yeah.
I mean, obviously, in terms of allergy trends, obviously we were very concerned when there was the Benadryl challenge that happened online, which unfortunately...
There was a Benadryl challenge?
There was. This was a couple of years ago.
What was it?
And it was about taking lots of Benadryl. But unfortunately, there is a lethal dose of Benadryl, which many people don't realize. And so you can die. And actually, we had a couple of teenagers who did pass away from this trend of taking multiple tablets of Benadryl. I'm not even sure how the trend started.
What would be the point of it? Just see who can take
It's kind
the
of
most?
like the cinnamon one, too.
Okay.
So there was many things that kind of started where you were like, I'm not sure what the purpose was. But that one, unfortunately, it's very dangerous. Wow. Which I think people think medications over the counter are not dangerous. Mm-hmm. But many of our medications over the counter, if you go past the safety limits, if you don't, pay attention, they can be dangerous.
Yeah.
And so I think that would be something very important that, was very concerning that I saw. And thankfully, there was a lot of kind of media around it trying to discourage it because it was very much in teens doing it. And so that was a good one to be moved away. The other thing I think that I see a lot of is advertising of these where you can just order an allergy test online.
Oh, yeah.
Yeah, send in and find out all the foods you're allergic to. What I would want to tell people is a lot of the tests that blood work that you get, and these come get your IgG blood work, this is actually often looking at an antibody that is present after you've ever been exposed to something.
Okay.
Your IgG is an antibody that I would look at if you have been vaccinated to, let's say, influenza. I would check the IgG to influenza to see if you're vaccinated. It tells me you've been exposed, you have antibodies to it. That's what it says. So every single thing you eat, you also make IgG to it because your body's like, yep, seen that, done that. Okay, yep, seen it. And so that's all it tells people. And people will say, I got this, and all the foods I'm eating all the time were at the top of the list. Yes, I would expect them to. You eat them all the time. Your body has lots of IgG to them.
Yeah.
But, and then people will say, I did this whole thing. I cut out all these foods and I still don't feel better. Yeah. But IgG to a food is actually not a bad thing. Mm-hmm. When we have people with true food allergy, there's some therapies that they go through, like, for example, oral immunotherapy, where they try to slowly desensitize them. Yeah. And one of the ways we actually look at how well it's going is to look at the IgG. Okay. So IgG is a good thing. And actually shows us a little bit of tolerance to a food. So these kinds of trends where you see online all the time saying, why don't you just order it? You can just send in a sample, or you can just go pay $400 at any lab for it. Unfortunately, gives you information that's not very usable. Yeah. But I understand why people want to figure things out, right?
Yeah, of course. Yeah.
If you're not feeling great all the time, you want to figure things out. Yeah. It's just unfortunate. I think it's, it's becoming a little, I think, predatory for people because they're really hoping it's going to help them. And then they're losing money and time cutting out things. Yeah. Or when people use it, I get very concerned if you use it for someone who's not able to make the decisions themselves. Mm-hmm. So sometimes people say, well, I read somewhere that if your child has autism or if they have any of these issues, then you should cut these foods from their diet. Mm-hmm. A lot of children who have things like autism may have some issues with different textures of food, and they have might have a limited repertoire of food. So you're taking away from their small repertoire that they might have. Not everybody with autism has very small, but some of the kids I'm thinking of who are quite affected. Yeah. And so you're taking away from that. You can risk them having things like malnutrition because they don't want to eat the other things. Yeah. B, when you take a food that's a major allergen away, especially in a child, and they stop seeing it for a long period of time, you can actually, unfortunately, then develop allergies to it.
Oh, really?
Your body needs to keep seeing things regularly to maintain that tolerance.
Oh, yeah. Okay.
So,
that makes sense.
That's really important.
Yeah.
So it's even when we talk to parents, like introduce peanut, around 6 months of age, not once. You have to keep it in the diet like weekly for the first few years, and then maybe it might be once a week, once every 2 weeks after, but it's important to keep seeing this to maintain tolerance. So taking something away from a diet can actually be dangerous too. Yeah. So for many reasons. So those are some of those trends that I get very worried about because there's not a lot of fact checking on any of the social media platforms. Yeah. There's none actually. And so but something could have a lot of views, and
people
number
believe
of
it.
Views does not mean that it's actually true.
Right, but it could be enough to make someone believe that it is.
Exactly.
I was wondering when you were talking about maybe a baby start to introduce peanuts at like 6 months or something. This might not make sense, but for a kid who does have that allergy, is it possible that they were not exposed to it then as a baby or a child, and maybe that's why they developed the allergy?
Yeah, it does play a bit of a role. We know that because there was a shift. So initially, we didn't have tons of food allergy. Then we started seeing lots of food allergy. And some people hypothesized maybe we're giving peanut too early. And so for a while, they actually said, introduce peanut later.
Okay.
And some of the North American and European countries did that. And what we saw was actually an increase in food allergy.
Okay.
Because we delayed the introduction. So, but then when we went back and we looked at other countries, we said, okay, let's look at other countries that have low levels of peanut. What are they doing differently? Yeah. And when you studied those other countries, you found, wow, they introduced peanut very early, around that like 4 to 6 months, whether it's like little meltaways with peanut or in some places they just take like fresh peanuts, boil them and ground them up as like a baby cereal, like a weaning cereal. So those countries, when you looked at them and you studied children, you found, wow, the early introduction actually was associated with decrease in peanut allergy. And so now we're really pushing for that early introduction. And so now when we talk to families, anywhere, babies start to be interested in solids and being able to tolerate solids somewhere in like the 4 to 6 month age group. You have to look at all the signs. They're sitting up by themselves. They're interested. They stop pushing their tongue out when you try to put something in it. And once they're ready, then that's when you can start the solids. And we recommend starting these kind of highly allergenic foods early. Okay. And starting them from then and then keeping it regularly onwards.
Wow. That's really interesting. You are the first Black female president of the OMA. What does it mean to you to be a Black physician in a leadership role in medicine?
Wow. Being in this role is really important to me, to my community, to the entire community, really, because I think it just showcases for other Black youth, children, that they can be in any of these roles. Yeah. It is important to have representation, to see yourselves in these roles. And so for me, I think of even just like in my office when I get like little Black girls coming into their office and their moms are so excited and you see the moms really smiling and the little girl's looking at me, she says, she looks like me. And their mom is like, yes, you could be the doctor. Like this could be you. And it's just like that moment. And that's when I was like, this is really important. Yeah. Because her seeing that lets her know she could be here too. That must make you so proud. Yeah, that's amazing. And I think that I didn't fully appreciate it till I was older. Like I think my parents were very big about this. I remember being in my undergrad and they would constantly be like, okay, we talked to someone, their kid is interested in going to university or pursuing something in the medical world. Yeah. Here is their number. We want you to call them and talk to them. Or when you're home next, meet with them. And, you're in your undergrad, you're like, what? I'm just trying to survive. Right. But my mom would say, you never thought about going to university. You thought, I was like, it was expected, Mom. It was just understood, yeah. It was understood. And she said, yeah, but not all these kids are thinking the same way.
Right.
And, you never thought university was not an option for you.
Right.
And some of these kids may not have thought it. And so she was like, I want them to talk to you. I want them to know you look just like them and that you're going to university and you want to go beyond your undergrad and that you want to go into medical school, and just for them to talk to someone who's gone through it and who's there and to know that they would have a space there.
Yeah.
And, they really felt that was very important. And, I see it more and more as I continue, like just how important it is to have those kinds of mentors, people to look up to in whatever you want to do.
Yeah.
And I say that to everybody. I say, you know what, and do it your way. Most people who want to do medicine sometimes feel like even just going into medicine, I have to do like, biology and I have to just do science, MCATs, like don't sway away from this. But I say, you know what, do what you like. Like, I love math. And so my undergrad is like half physiology, half math.
Oh my gosh.
And I did a master's in math. Why? Because I love math. And I always thought you did your master's in things you're really interested in.
Obviously.
And so that's what I did it in. But many people were like, wow, aren't you chancing it? Will you still get into medical school with this alternate pathway? And I said, alternate pathway? All of the research is based on statistics.
I was going to say it's in math of all things.
Exactly.
Like,
But many people still feel like you have to be so structured. You have to do it this way.
Yeah.
And so often when I even meet with kids, like I had a chance to go to Northern High School and just talk to a lot of the students there.
Yeah.
And they said to me, well, what do you think I should take to get into medical school? And I said, you know what? You want to excel in what you're doing, and because that joy really translates into how you do in your classes.
Yeah.
And I loved math. I did well in math. That's why I chose this. Yeah. And so it's important to do that. And for me, I always tell people, I'm like, listen, you can be here, but you can also still have varied interests if you want to do medicine.
Yeah.
And I tell people, look out for people that are interesting to you that you like what they're doing, and don't be afraid to ask questions.
Yeah.
And so I hope that, out there are, young kids, and kids like really any reason where they felt othered, whether it's by race, religion, sexual, if anyone's just speaking like, you could be here. Yeah. Because there's a lot of othering, like, still being a woman in a leadership position, being Black in a leadership position, all of these culminations, I think that's important for people just to see that you don't have to be what's considered the status quo to be in leadership. Yeah. And I think that's why it's important.
That's amazing. Absolutely. Just seeing, like you said, someone that looks like you, and it doesn't have to be what you've maybe known it to be. And that's why representation is huge, because it inspires the younger generation. I just, especially, all Black kids, I'm sure that any patients that you see, but especially Black little girls, I would imagine that would be so empowering. That's really, really sweet. Is there any piece of advice or message that you would give to young Black doctors or medical students?
I would say to them, take your time in terms of sometimes there's this kind of rush aspect. You have to be everything everywhere. I think, pause, ensure that what you're doing really resonates with you. There's always, lots of join here, do this. There's a lot of work out there. Make sure that you are also keeping you for you, remember who brought you to where you are. We all have a community behind us. Make sure you're connecting. Yeah. Because sometimes you can feel very isolated. There might not be lots of people who look like you in whichever of your endeavors. Yeah. Right? So, I was lucky in my med school class there. I think there was about 12 of us, know. But, in other years, there are much less. Yeah. And so now, so keep in touch with your community and keep in touch with the people who brought you here. Yeah. And they'll also remind you who you are. And the times when you feel maybe isolated, tired, check in with them. Check in with yourself. Yeah. There's, I think, a big part of medicine that's just like go, 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 don't stop. And I think it's really important to be well. Yeah. And, I think I would say rest is resistance. Yeah, yeah. And to pay attention to that, because you'll feel pulled in so many different ways. Yeah. And you have to preserve yourself is what I would say. And to know that you have a bigger community that's also supporting you. You may not know me, but I'm supporting you. And, we're all part of this bigger community. And once you're here, we're all supporting you. And, feel free to reach out. And, sometimes it's about also not being afraid to make those connections, like go up and say hello to somebody, So I think that that's important, and the community is there for you.
Rely on it. Rely on your community. You touched on this a minute ago, but I'm curious to know if, more in detail, I guess, if representation or lack of it, if that affected your experience in med school or any sort of medical training.
Yeah, no, absolutely. I think that it does play a big role. When you looked at it, I was lucky. Like, my dad is a black doctor, so I had that, and I was very lucky in terms of that exposure. But, it is interesting when you do get into, like, I know for myself in med school classes, yes, there was a few of us, but there's like about maybe 12, maybe it was up to 14. But our class is 200 people. It's still not reflective of the greater population. And I think that, I think about those times of like how they started the Black Medical Students Association at U of T, which is where I went to med school, and how that was so important. And they really made sure to kind of pair and mentor people with people who are in the areas that you might be interested in. And they really ensured to foster that. And I remember when the other schools, not everyone else had it, but now that they do, how important that has been. And I know when I talk to like medical students now, I say, if this is in your school, or if you don't have a branch, here is like a link to the larger one that's like across Canada, just to have that, because it is important to have those linkages to be able to meet staff, doctors who are in wherever you are for medical school, and I think about how it really helped shape it for me. It's important to meet other physicians that you hadn't met, who were kind of following, who had gone through these pathways as well. And I think, as I moved forward, there can sometimes be much less, I think of in the allergy world, if you told me, even in Ontario, if you told me you saw a Black allergist, I would be like, okay, well, here's the list on, one hand. And so, it does become smaller as you move into a lot of these spaces. And I think that it's important to talk about it. And I know that, sometimes it's uncomfortable for people. And I said, I've taken those opportunities to talk about it. I think of in around 2020, 2021, I got to speak at the British Society of Allergy and Clinical Immunology on racism in medicine. And just something that we don't often talk about. And how it does more adversely affect any groups of minorities, Black students.
Allergies.
Just in terms of the racism in terms of them feeling it while in medicine, whether it's in training, in residency. It does, and just thinking like that intersection doesn't change because we're in medicine. We're still experiencing racism, and talking about and having these frank conversations because not everybody would have them. Whether it's sometimes even in practice, people will say, wow, where did you go to medical school? And I will say U of T. Have you heard of it? People will ask you, and they're like, "Oh, you." People will say you speak English very well, and I'll say thank you. It's
people say that to you?
Yeah, because and I say to them, well, yeah, thank you. It's my first language due to colonialism in my home country. That is my first language. It probably shouldn't be if you really think about it. But that is also, but thanks for bringing it up.
Thanks for being impressed by the fact that I can speak the language I was taught as a kid.
It's very, so like, you'll have that more so. Any of the racialized physicians will tell you, you'll have more of these kinds of comments. People sometimes call them microaggressions. Sometimes they're pretty macro, really, and so, people will say, where did you go to your medical school? Where did you train? And I say, if you're very concerned about any of this, it's also all on the CPSO as well. But, people asking more of that. And I think also we have to have these frank conversations with our trainees about that. Or if they're in a room, they don't feel comfortable or safe, that they could come out and tell us. Right? So I think that I think about those times and how I could have used more people having these conversations.
Yeah.
That I think now when I do come across people in training, I do talk about it.
Yeah.
And I say, have there been any times that you felt uncomfortable?
Yeah.
Have you, had experiences? Do you want to talk about them?
Yeah.
If you're ever experiencing something like that in my office, you can come right out. You can just say, actually, I'll be right back. And you just step out.
Yeah.
No problem.
Yeah.
Let me know.
Yeah.
And I think that not everyone had those kinds of conversations when I was in training.
Yeah.
And so for me, I make sure I do.
Okay. Yeah. Yeah.
Like even when we set up our office, I tell people all the time, I said, when you're setting up your office, there are important things to think about. I think of where I'm sitting in relation to the door in case of anything kind of happening where you could leave in case someone did become violent or something, that you have an escape route and how these are important things.
Yeah.
And I remember saying this to some of our female trainees coming through, and they said, wow, it's interesting. When I was with a male physician, that wasn't what their concern was. They had set up their office slightly differently for other reasons. I said, well, you know what? As a female, I do think about this.
You have to think about it. Yeah.
Exit strategy. So, some of these are the things that you think about and that's why it is important about representation.
Yeah.
Sometimes your lived experience, your viewpoints can vary, and it invites people to be able to feel comfortable to ask those kinds of questions.
Yeah. I can imagine that. Like just even you volunteering the conversation must be really helpful for trainees in the process right now. Just like knowing that, okay, there's this can happen, and you volunteering that conversation maybe to be the one initiating it so they feel comfortable joining it. So you feel like the conversations are happening more now?
I think they are. I think that there's been a lot more discussion with it, even in medical school curriculum. We're talking about it a lot more. We're talking about how, even the way we're taught is, Is
it different?
Yeah, well, we didn't get taught a lot of diversity. So even when you look at dermatology textbooks, a lot of the skin of color wasn't shown as much.
Yeah.
And if it was always some very certain disease states that were only shown in there.
Yeah.
And now, there's a lot more looking at skin of color, looking at presentations in different skin tones.
Yeah.
So even that aspect, it's also to think outside of the box with presentations. I remember in training we had 2 kids come in. I was on my pediatric surgery rotation at that time. We had 2 kids come in with rectal prolapse.
Okay.
Now, this can be a sign of, it can be immunodeficiency. It's also very associated with cystic fibrosis.
Okay.
And there's a few other, but those are kind of the 2 things you think of right away. One was a little black baby boy, and the other was a white baby boy. And I remember I said, we have to do the cystic fibrosis testing for both. And I remember one person said, the black kid isn't going to have cystic fibrosis. And I said, but why not? And they were like, well, genetically, we typically more see this in white populations more so. And I said, we should definitely, I said, well, I'm the one writing the orders. I'm writing it for both.
Yeah,
They're both getting tested for CF. And we're going to do their immunodeficiency workup and all the other workup. And who had CF was the little black boy.
Wow.
Right? So it's like that thought of remembering that we have to think about these.
Yeah.
Even if it's more common in certain populations doesn't mean it's not in others. So it's those kinds of things. I think back to those times and just saying, no, we're going to test this.
Those extra things that you have to think about.
Yeah.
Was it a medical professional who said, no, we don't need to test?
It was another trainee who was ahead of me. I was a first year.
I see. Okay.
And I just said, no, we're going to do this.
Yeah, of course. Because why would,
I was like, it's also, this is an important test that you should do for everyone every baby who presents with rectal prolapse. This is like a PEDS thing. You test for CF. Yeah. And we don't take into account anything else.
Yeah.
So you might have a lower, pretest probability, but it's not 0.
It's not nothing.
So, so it's like things like that, talking about that. And so I can think of those times in training and thinking now as we're teaching, we're talking more about how you have to consider this might look differently here.
Yeah.
Being aware that, we talked a lot in pediatrics about some of the there's a type of nevus or skin. It's not quite a mole because it's kind of a bit flatter, but it can look like a little bit blue on some of the young babies, and you can more see it sometimes in babies from Asia. And explaining that you have to recognize that is actually just like a skin issue, and it's not a form of abuse. So kind of talking about things like that, how things look on the skin. So that's why it's important for us to think about this. And it's also important that we're teaching, like, here's the different ways this condition looks here. But you know what? Eczema looks very different in different skin of color.
Absolutely.
And that's like a very common thing. But, if you haven't seen it before in other skin tones, but even like how to recognize melanoma. Right? And sometimes people don't think of it in people who are darker, right? Because they're like, well, you're darker, you're more protected against the sun, meant to live closer to the equator. Surely you couldn't get melanoma, but actually, Black people do definitely get melanoma. You don't see it often in necessarily the skin exposed, like the sun exposed areas. You'll see it on like toes, fingers, scalps. Like, so places like you also have to think about this for the difference. So that's why it's important for us to keep having these conversations right from training, so that people are fully open and they can be the best that for any population coming into the door. Because we are meant to treat everybody.
Everyone, exactly.
So you have to know what it looks like across everybody.
Right.
And you can't only show it in certain skin tones.
Because then you're not learning everything.
You're really not.
There's more that you can be. I remember seeing kind of recently, people were talking about in obstetrics training, like delivering babies, a lot of the what is that called? The fake babies that you.
Oh, yeah.
Why can't I think of the word for the?
Like the training ones.
Yeah,
like
the training.
Models?
Yeah, the model babies were. Usually they've been white babies, but I've
even
seen
CPR, like all of those.
Everyone's usually white, but I've seen a few videos of people talking about how some of them now are Black babies or Black women delivering, which is just, again, another part of representation, because you're not you're not learning everything that there might be more that you're missing if you don't know what to look for in a different color skin. Wow. Well, thank you for talking about that. That's really interesting. I'm curious to know if there is a patient story that maybe stuck with you. You don't obviously identify anything or anyone, but if there's one that comes to mind that sticks with you throughout any part of your training or your practice.
I can think of two.
Okay.
One is just very interesting and kind of cool. The other one kind of relates back to what we were talking about, skin of color. And I remember I was a pediatrics resident, still my training. I think I was the senior resident at that point. And they had come in, and the referral had been from the Emerge. They were worried. They said they had seen a really atypical rash on this baby. They didn't know what it could be. Like, they were like, it's a very young baby, but we're like, could it be like a T-cell cutaneous lymphoma, or is this like some weird immunodeficiency? And I remember thinking, whoa, okay, like they're worried. All I know is they've seen a rash on a small baby, and they're worried about it. And they even could it also just be abuse? Like, we don't know, because it's also like in the diaper area, like just outside the diaper area. They're like, we don't know what this is. And I thought, okay, let's I have to go assess the baby, because I have to also make sure it's, baby's like safe before we would send off anyone else more junior to do the full consult. You always want to check and everything. And I remember going in and I was like, okay, like the baby, I was like, okay, the baby's fine, everybody. The baby's fine. The baby has eczema. But it's really like the baby had very dark skin color. They were Black, and they had quite significant eczema, which can look different in Black skin, and you can have it where it looks a little bit bumpier, and so it was like all over, and they were so worried about all these other things, and I think they would also prepped the family like, we're not sure this might be. And so when I went in, the family was also already crying.
Oh, my gosh.
Because they were so worried. Oh, no. Because I get it. If you're worried about something and someone comes in, you don't want the team to be like, well, we heard that there's a concern about something potential. Yeah. So I get that they were like, we're worried. This rash just looks so different. Okay. And so going in, and I remember seeing the baby and being like, this is really bad eczema.
Yeah.
But it's eczema.
That's what it is. Yeah.
It's still eczema. And so now you're like, okay.
Yeah.
Whew, let's
Okay, that's
take
a
a
lot
moment.
more, yeah.
And so the family is already like, is our baby going to die? Like, it's a lot.
Wow.
It's like a little wee baby, just a few months old.
Yeah.
And I was like, okay.
Yeah.
And I said, what's been going on? Like, how? And nobody else had really picked up. They were like, well, they said, could it be eczema? But they said it should be more red. And I was like, well, how much more red? Like, when you mix red with some dark colors, it becomes more purpley. So everyone was worried because it looked a little bit purpley.
Okay.
And I was like, okay, this is normal.
Yeah.
And so that was one of those times where it was like, wow. And just like how much the family had to kind of.
Yeah.
Yeah. So I think about that. And then the other one I thought was very interesting. Was when I saw this little baby out east when I was doing an elective in Halifax.
Okay.
Doing an allergy elective, and they they had brought in, because the baby had reacted to whale blubber. And I remember being like, wow. This is so cool. I was like, because anything you eat, you could potentially react to. We don't eat a lot of whale in our diet, but some populations do.
Oh my goodness. Yeah.
Yeah. And so I was like, wow. And we were like, please bring a sample of the food when it's not something that we naturally have on the tray. And I remember being like, this is so interesting.
Yeah.
But then also realizing culturally for that child, it made a huge difference because that is a huge part of their diet through the winter months.
Wow.
And just like, wow, that moment where you realize like culturally appropriate foods and how this can totally affect a whole family.
Yeah.
So it's just two of those times where I was just like, wow, you really need to have this lens to understand the impacts.
Oh my gosh,
So I always think about those babies and just how, you just... in one sense, it was like really cool for the food because everyone's like, I've never seen whale blubber allergy. And I said, guys, do you understand what this means for this family?
Right, yeah.
Culturally, where they live. Because they were coming, even though we're in Halifax, they were coming from Labrador.
Okay.
Because there's not tons of allergists.
Right.
At that point. And so they had come in and I said, guys, let's think. I know it's really cool, but like, what's going to happen dietary-wise? This is a huge
Other things to think about, yeah.
They use that a lot in a lot of the food.
Yeah.
And so everyone was like, wow, this was really cool. But then all of a sudden we're like, we have to think about this from the cultural dietary perspective of the whole family, the whole community for them. So
how did you approach that with
then we had to say, I was like, what else do you tell us about the rest of your diet and how will this be very limiting? And so we were able to have those. So
Well, thank you so much for coming and talking with us today. This was really interesting, and hopefully we'll have you on again. And just thank you for sharing everything. That was awesome.
Thanks so much.
Bye everyone.
Bye.